Hello, and welcome to another emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel. I'm your host today, and you can type your questions into the chat pad if you have a loved one critically ill in intensive care, or if you have any questions in regards to intensive care at home. And thank you so much for watching this. If you're watching it live, that's great. Type your questions into the chat pad. And I know there's quite a few viewers that we get on replay. Thank you for those viewers as well. And if you like what I'm doing here, subscribe to my YouTube channel for regular updates. Click the like button, click the notification bell, and send your comments in, of course. You can also connect with me live here today. You can talk to me directly by clicking on the StreamYard link that I'm just posting in the chat pad. Now, before we go into today's questions, what makes me qualified to host an emergency questions and answers for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm the founder and director of intensivecarehotline.com. I have been, and also the founder and managing director of intensivecareathome.com. I have been working in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse unit manager for over 5 years in intensive care and critical care. And I can confidently, very confidently say that we have saved many lives with our consulting and advocacy here at intensivecarehotline.com. And you can verify that on our testimonials section, and you can also verify it on our intensivecarehotline.com podcast, where we have done client interviews. And when I say client interviews, we've mainly interviewed our client families, of course, but we have also one podcast where we have the patient himself on the podcast, where the family was told he would not survive intensive care and that they should just give up. And with our help, they weren't giving up. And then he was ready to share his story about 12 or 18 months later on our podcast. You know, for someone who was quote unquote meant to die and didn't have a chance, you know, a year later he sits on a podcast and shares his story. That's how life-changing our work is and can be. With Intensive Care Hotline, we are providing consulting and advocacy for families in intensive care all around the world. And we also have a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com. I'm also the founder and managing director of Intensive Care at Home. And you can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home, predominantly for long-term ventilated adults and children with tracheostomies, but also for home TPN, home IV potassium infusions, home BiPAP, home CPAP, tracheostomy care at home without ventilation. We're also providing central line, peak line, Hickman's line, and portacath management at home today. At home. And we're also providing ventilation, meaning we're providing nasogastric tube management, PEG tube management, and palliative care. We're also sending our critical care nurses into the home for emergency department bypass services. With Intensive Care at Home, we're currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved, TAC approved, and WorkSafe. NDIS is all around the country, TAC and WorkSafe in Victoria, and iCare in New South Wales, and IISQ in Queensland, as well as DVA and Department of Health. We're also providing level 2 and level 3 NDI support coordination and TAC and WorkSafe case management in Victoria. Now, without further ado, let's look at the questions that have come in during the week and also at some comments that clients have made. And I want to start with an email from Peter, who responded to an email we sent out this week to our email newsletter subscriber list. And the email that went out to our subscriber list this week was a quick tip for families in intensive care. How quickly should you get advocacy when your loved one is critically ill and ventilated in ICU? That's a quick tip that I've made recently. And Paul sends an email back and he says, Paul sends an email back and he says, great subject matter, as I feel this is very beneficial to all ICU recipients and their families experiencing these health concerns in ICU, especially after having been through it myself and seen hospital tactics firsthand. Thank you for helping to raise awareness. Yeah, I think that is part of what we do. We are not only raising awareness, but we're also getting very tangible results for our clients, right? I mean, that's what our consulting advocacy is all about. It's not just hot air. It is getting results for our clients. I'll give you a very other good example. So this week we were working with a client who had their 19-year-old son in ICU, still has their 19-year-old son in ICU. He went into ICU in mid-December. At the time of me recording this video, we are mid-January, 12th of January we are today. And initially he went into ICU for severe lung failure after asthma, and he ended up on ECMO. Just for those of you who wonder what ECMO is a form of life support that can take over the function of the heart and the lung for a period of time. And it basically helps for someone in lung failure to let the lungs rest and heal, which is what ECMO did in this situation. So the young man came off ECMO eventually, then ended up with a tracheostomy because he was a slow respiratory wean, which can happen after ECMO, right? So especially with lung failure, I'm not overly surprised that he ended up with a tracheostomy. Now, when he had a tracheostomy, he ended up on literally truckloads of sedatives and opiates. And I have to read out the list because the list is so long that even I went like, oh my goodness, that is very unusual. And before I give you the list of sedatives and opiates he was on, you know, one of the things that I have said over the years many, many times, and you will also find other literature about this, the goal of a tracheostomy in intensive care is to wean off sedation and opiates as quickly as possible. Case in point, you know, when you do a tracheostomy in ICU, prior to that, patients on a breathing tube might be on opiates such as fentanyl or morphine. They might be on benzodiazepines such as Valium or midazolam/Versed. They might be on propofol or Precedex. The minute a tracheostomy is done, it should be removed immediately. It should be removed immediately, right? Now, sometimes you have to go slow and you have to go step by step, depending on how long the patient has been on opiates or benzodiazepines, because both opiates, such as fentanyl or morphine, are highly addictive in nature. So you might have to wean it off gradually, because if you stop it immediately, patients go through withdrawal. They might get agitated, they might get confused, they might get delirious, right? They might get combative. You don't want that. That's why you should minimize the use of opiates to begin with. The same is applicable to benzodiazepines such as midazolam/Versed, Ativan, diazepam. Right? They're highly addictive in nature. So that means if a patient has been on too many of them, you have to wean it off gradually so people don't go through withdrawal symptoms, the ones that I've just explained. Now, coming back to our client this week. So the client, after he had a tracheostomy, was on Dilaudid, which is an opiate, a very strong opiate, Dilaudid, also known as hydromorph. He was on fentanyl. He was on ketamine. He was on midazolam/Versed. He was on diazepam. He was on propofol and Precedex. It's pretty much any sedatives and opiate, the most commonly used sedatives and opiates. Now, if someone needs sedatives or opiates in ICU, it should be minimal. It should be one sedative, one opiate, if that, right? Ideally, only use one sedative and one opiate, ideally, right? Because deconditioning in ICU is real. When someone is kept in an induced coma with sedatives and opiates, they are deconditioning, right? It's like, think about if someone would tie you to a bed for weeks on end, you would decondition without sedatives, right? So now you've got an immobile patient in intensive care and you're giving sedatives and opiates. It's not a good situation. Now, coming back to our client this week, they asked me to get on a call with one of the senior nurses in the ICU, and I, was very friendly, and I asked them, what's the purpose of, keeping all these truckloads of opiates and benzodiazepines going? And they were saying, oh yeah, trying to wean him off, and but it was simply too slow. And then 24 hours later, the client sends me a text message and basically says, thank God you've spoken to them. Now he's only on a smidge of fentanyl. So, that's another success story, really, to showcase how our consulting and advocacy makes a big impact. Now, once again, to illustrate, the purpose of a tracheostomy is to wean someone off a ventilator as quickly as possible. You can't wean someone off a ventilator as quickly as possible if a patient in ICU is on truckloads of sedatives. Now, that also ties in with a quick tip that I made this week that I also want to quickly highlight. So some of you might have watched a podcast that I've done with Carly Dayton from Carly Dayton Consulting. Carly is a critical care nurse in the US, and she's got her own consulting practice, and it's called Awake ICU. And Carly is incredibly successful to advise ICUs not to use sedatives and opiates and have patients awake on a breathing tube. It's not common practice yet, but it is getting more common with Carly's work, right? So if Carly and her work and the colleagues can leave patients on a breathing tube without opiates or sedatives, there definitely doesn't need to be any sedatives or opiates for a tracheostomy patient. Again, like with everything, there's few exceptions to that rule, but generally speaking, it's not necessary. So, Carly made some posts on LinkedIn this week, which I found quite interesting, which really caught my eye, and I want to talk about Carly's posts that she posted on LinkedIn this week. And also, if you want to know more about Carly's work, you can go to my intensivecarehotline.com podcast on our podcast section, and you will find a couple of podcasts that I've done with Carly in the last couple of years. Really great work that she's doing. Shout out to Carly. So, what is Carly saying on the podcast? Go and talk to your patients in ICU and ask yourself the following questions. Do they respond to voice? Do they have an indication for sedation? Is there a contraindication to mobility? Was an awakening trial done today, and how was it done? Why was sedation resumed? What RAS is charted versus what I am seeing at the bedside? Is this false documentation? Is this giving more medication than was prescribed? Has this patient really been screened for delirium? Was it done properly? Should we be depriving these patients of communication, autonomy, and mobility? Can we afford the significant costs in money, lives, and quality of life to treat all intubation patients this way? After you've asked all the questions, let's chat. We'll have a lot to talk about. Obviously, this post is addressed to health professionals in intensive care. But it doesn't really matter because, families in intensive care need to ask the very same questions, right? So then she carries on. Healthcare leaders, CMOs, CNOs, CFOs, critical care directors, nurse managers, respiratory therapy directors, rehab directors, please walk around your intensive care units. Spend 30 minutes there during the day and soak it all in. Please ask yourself the following questions. Are most to all patients awake? Is sedation running? Is there a chair for them in the room? Are they out of bed and in the chair? Are their patients walking in the halls? Are intubated patients able to communicate with their loved ones and caregivers? If more patients look like the patient on the left than the patient on the right, I invite you to take a deeper dive. Go and talk to these patients and ask yourself the following, and then she carries on with the questions that I highlighted earlier. And, I really want to focus on, is there a chair in the room? A good ICU will mobilize patients, regardless of whether they have a breathing tube, tracheostomy, or no breathing device at all. Right? It's as simple as that. If a patient is not being mobilized in your ICU where your family member is, your loved one is not in a good ICU. They're in an ICU that pushes their own agenda. Right? Also, the pictures that Carly is referring to, there's one picture that she posts on LinkedIn that's an intubated patient that has her smartphone in her hand, right? So she's typing away on her smartphone. And there's another intubated patient that's fast asleep, looks like they're in an induced coma, right? So we've been advocating for mobilization in ICU from day one. And like I said, a good ICU will always advocate for mobilization. The outcomes are so much better. And here is why. When someone is ventilated in particular and they're confined to a bed, they're much more likely to develop a pneumonia. And a pneumonia could simply kill. Right? A pneumonia is also much more likely to keep your loved one on the ventilator for much longer than necessary. Right? And if an ICU tells you they don't have the resources to mobilize a patient, I call nonsense right away. I'll tell you why. The only contraindication really that exists for patients not to mobilize in ICU are twofold as far as I can see and from my experience. If someone has fractures, right? But even so, depending on where those fractures are, you might still be able to mobilize. If someone has a traumatic brain injury, and if someone is hemodynamically unstable, right? Those are valid points not to mobilize. Very valid and genuine points. Everybody else, I argue, can be mobilized. There's plenty of chairs out there where patients can get mobilized in ICU on a ventilator. Do not let dissuade you, anyone, that it's not possible. I'll give you another hint. If it screams common sense for you, it is common sense. So, what do I mean by that? A lot of ICU teams are trying to persuade you that what you want is not common sense or doesn't make common sense, and yet you know exactly that it is common sense. I will give you some examples today because I think it is very, very important to do a little bit of a deep dive there. Once again, if it screams common sense, it is common sense. And if the ICU team is telling you that's not what they do and it's not common sense, you can think for yourself. You can think for yourself. Once again, Don't let anyone dissuade you that you can't think for yourself. Right? So what do I mean by that? What is common sense? Common sense in ICU starts, for example, with end of life, right? How many times have you heard and have I heard that it's quote unquote in your loved one's best interest to let them die, right? It's because they wouldn't have any quote unquote quality of life in the future. How many times have you heard that? I have heard it millions of times. It's one of the reasons why I started this channel, one of the reasons why I'm doing the work that I'm doing, because I am strongly opposed to that point of view. Extremely strongly opposed to that point of view, because I know with all my extensive experience that ICUs want to empty beds as quickly as possible, and they want to empty those beds by any means, and sometimes it means that they are trying to tell you it's in your loved one's quote unquote best interest to let them die. Now, I argue your loved one wants to live. Now, once again, are there exceptions to the rule? For sure. Maybe your loved one has an advanced care directive where they say, hey, if I'm in such a situation, I just no longer want to live, and and that's the end of that, and that is okay. I can accept that. But most patients quite clearly want to live. Right? Most patients clearly want to live, and again, that is common sense. Once again, do not let intensive care teams persuade you that you can't make a distinction between what's common sense and what's not. It is common sense that your loved one wants to live. It is common sense that you want your loved one to live. Right? Once again, do not let anyone persuade you otherwise. If it looks like common sense, it is common sense. If your gut is telling you it's common sense, it is common sense. Right? Next. If you think your loved one should be weaned off the ventilator as quickly as possible to avoid a tracheostomy, that is common sense. Right? If the intensive care team tells you, well, we think your loved one needs a tracheostomy, you have to question that. Now, a tracheostomy has its time and its place. Tracheostomy can be a wonderful thing, but before a patient in intensive care has a tracheostomy, the intensive care team needs to do everything beyond the shadow of a doubt to avoid the tracheostomy. I've written an article about that and made a video about it, how to wean a critically ill patient off the ventilator and the breathing tube, and I encourage you to check that out if your loved one is on a ventilator with a breathing tube in intensive care. Right? That is common sense. A tracheostomy is a surgical procedure, right? And it's a surgical procedure in a risky area around the neck. Right? Nobody wants surgery around their neck, right? So, whilst it's a routine procedure nowadays, it should be avoided if you can. Once again, use common sense. Next. Mobilization. If you think that mobilization and getting your loved one out of bed while they're in intensive care is common sense, it is common sense. Like I said, what are the contraindications? The contraindications are fractures, hemodynamic instability, and traumatic brain injuries. Right? There may be a couple of others, but off the top of my head, they are the most common ones. Okay? Some of the ICUs that I worked in, we were mobilizing patients left, right, and center, whether they had a breathing tube, whether they had a tracheostomy, whether they had BiPAP, whether they were not ventilated, right? What does that do for a patient? I tell you what it does for a patient. And I will say it until I'm blue in my face because it is so important. When a patient is confined to a bed in ICU, doesn't get mobilized, their lungs are at high risk of collapsing, causing a pneumonia, right? Because the lungs can't expand when you're lying on your back, right? If you're mobilizing a patient and you're seating up your lungs can expand, your breathing muscles strengthen just by sitting up. That is one of the main ingredients to wean someone off a ventilator. If you're lying in bed, your breathing muscles deteriorate, they decondition, right? And weaning off the ventilator is getting more and more difficult. By sitting up, by getting mobilized, by doing physical therapy early on, right, your loved one has a much higher chance to wean off the ventilator. Much higher chance to wean off the ventilator. Now, next that I have what's common sense is not to use sedatives and not to use opiates. That's not to use an induced coma when it's not necessary. That is common sense. Right? And if the intensive care team is telling you, oh, if we don't use opiates or sedatives, your loved one gets combative, they get agitated, they breathe against the ventilator. Sure, I have seen that, don't get me wrong. But there's often a way to minimize sedation as much as you can. There's also a way of talking to patients, hand-holding them, working with them through that process of not needing as much sedation and opiates by explaining to them what's going on. Right? Talk to people. I also feel that in this day and age, often opiates or sedatives are a way to minimize interaction with the patient. We need to interact and talk to our patients as quickly as possible. Right? Next, what's also common sense, and it's getting more and more embraced, don't get me wrong, but what's also common sense, and some intensive care units do not want to embrace it as common sense yet, is intensive care at home. So, like I said in the beginning, in the intro, we're running a service in Australia, intensive care at home, and you can find more information at intensivecareathome.com. If your loved one is critically ill in intensive care and is stuck long term because they can't come off the ventilator and the tracheostomy, right? It is common sense to give patients choice and control, and it is common sense to let your loved one go home with intensive care at home, right? Because that creates a win-win situation, right? The win-win situation is patients and families want to be at home. Very simple, right? Families are tired of living in ICU. Patients are being tired of living in ICU, right? Next, it cuts the cost. Intensive care at home cuts the cost of an intensive care bed by approximately 50%. That's half. The cost of an intensive care bed is around $5,000 to $6,000 per bed day. The cost of intensive care at home is approximately half of that. Next, with intensive care at home, we're freeing up ICU beds. And as we've just heard, ICUs need beds. Right? And we don't want to kill people. We want to give people choice and control. Right? We don't want to go around in an ICU and saying, hey, this person here won't have any quote-unquote quality of life in the future, therefore we should just stop everything. A much better approach here is to think about how can we improve the quality of life for this patient and their family and give them the choice of intensive care at home. Right? Some patients may not want it, and that's okay. But we need to be able to create choice. But it's also choice and control for families, for patients. It's also choice and control for intensive care units. Right? So always bring it back to common sense. Always bring it back to common sense. You can't go wrong with common sense. And like I said to you, if it screams common sense to you and your gut is telling you it's common sense, it is common sense. Don't let intensive care teams and their agenda get in your way of what you know is true. Always follow your gut instinct and always follow what you know is common sense. Also keep in mind, you know your loved one best. You are the one that knows your loved one best. You are the one that knows and understands what your loved one responds to. And you and your family know whether your loved one has a chance of survival or not, because you do know how they react to major challenges. Okay, so I also want to quickly point out, if you have any questions, please type them into the chat pad or connect with me here on StreamYard directly, right? And talk to me directly here. You can talk to me directly by, you don't need to go on camera, but I welcome you to go on camera. And I welcome you to talk to me. Miguel Chicago says, thank you for your knowledge. It's a pleasure, Miguel. I always want to help wherever I can, right? And as a next step, I also want to look at one of our members that we are currently working with and some of the comments that he made, because they are also quite valuable comments for our audience, I believe. So let me just go through my emails and my recollections here. But while I'm looking up my emails, I really want to encourage you that you need to trust your gut and what you know is common sense. Right? If someone is telling you your loved one shouldn't live and it's in their best interest to die, that's not right. That's not common sense, unless, with the exception, your loved one has an advanced care plan where they have clearly documented that in certain situations they do not want to have life support continued. Okay, so other questions that have come in this week, which I also found very interesting. We have a client now, she's one of our members, and her dad is in ICU on ECMO, right? And interestingly, she's an RN herself by background, but she's not ICU trained, and she said, look, whilst my dad is in ICU on ECMO, I want to make sure that I ask all the right questions. So what happened is her dad went into cardiac ICU this week on ECMO, right? Initially, he was a little bit confused, and then he ended up in ED, in the emergency department. Then they took a chest X-ray. Then they started panicking, and then they put him on high flow oxygen, but then he went into cardiac arrest, and then they did CPR for 15 minutes. Eventually they got a pulse, and a few minutes later he went into cardiac arrest again, and they did CPR again for another 10 minutes. And here's an interesting comment that she made. She said that her dad's preference was longevity versus quality of life. So they asked, do you want to give him medications to keep him comfortable till he passes, or do you want to do this other option is called ECMO, and I'll talk about ECMO a little bit in more detail in a minute. So they went with ECMO because that's what her dad wanted, which is good. I'm glad to hear that, her and her dad's wishes were respected. And now he's also on dialysis, right? And then she says, in this situation, I don't really know what questions to ask. I'm completely out of my depth, and I need someone on my side to know what questions to ask, because I've never experienced this before. So I saw your videos about ECMO, and that's where I thought I'll reach out to you and see what help you can offer, right? And our member's dad here, he's on ECMO for heart failure. ECMO is for two organ failures, two types of organ failure. One is for heart failure, one is for lung failure. In this situation, her dad is on ECMO for heart failure, right? And also leading up to this, her dad was actually on a heart transplant waiting list. So his heart was already quite weak. and he had a heart attack about a year ago, and that's why he ended up on the heart transplant list. Then another thing that is really important to know here, that with ECMO, so here's what ECMO does. ECMO is able to take over the heart function or the lung function, or sometimes both, so that the heart can recover, right, or the lungs can recover. Now, if for whatever reason the heart can't recover, right, it's still buying time for patients to potentially receive a heart transplant if they qualify for a heart transplant, or they might go on an LVAD, right? LVAD stands for left ventricular assist device, also sometimes an RVAD, right ventricular assist device. It basically can take over the function of the right ventricle or the left ventricle of the heart, also, you know, to help the heart recover and recuperate and take over some of the function of the heart, right? And also for this particular client, remember, her dad is only 51, very, very young. So what do we do in a situation like that, right? We look at medical records. The client has now given us access to the medical records. We look what the ECMO is doing. You know, we look whether there's a chance that they can wean off ECMO. So with ECMO, and I have looked after many ECMO patients myself when I worked in ICU, whether for heart or for lung failure. With ECMO, you know, it eventually needs to be weaned off, right, to see whether the heart is beating again. And also an ultrasound or regular ultrasounds of the hearts need to be done to see whether the heart is recovering. What is a patient's ejection fraction, right? Ejection fraction is basically referring to the contractility of the heart or the pump function of the heart, right? Also, when someone is on ECMO, they are most of the time on anticoagulation, such as heparin, right? And when a critically ill patient on ECMO is on a heparin infusion, right, that is also a high risk factor, because a patient could end up with significant bleeds, right? And there are numerous risks that are attached to that. And that's also why it's so important for you to understand. For you to understand what's happening, right? If you don't understand when your loved one is critically ill in intensive care, what is happening, you know, the devil is definitely in the detail, right? The devil is in the detail. And if you don't understand the ins and outs, you know, you are fighting an uphill battle, right? You are fighting an uphill battle, right? So when someone is critically ill in intensive care, whether on ECMO or not on ECMO, there's dozens of things happening simultaneously. What do I mean by that, right? So what I mean by that is, starts with when someone is ventilated. You know, sometimes clients tell me, oh yeah, he's on pressure support of 10. Then I say, well, that's one of the 10 other numbers you need to look at on when someone is on a ventilator, right? The biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's exactly what you're up against here. Now, here's another thing. I forgot to mention that earlier, actually, when I was talking about mobilization. ECMO, most of the time, not all the time, is also often a contraindication to mobilization, right? Also depending on where the ECMO cannula sits. Sometimes the ECMO cannulas sit in the groin, and then you can't sit up, right? Now, also, when someone is on ECMO, right, there are more tests, blood tests being run than on other patients, right? Especially when someone is on heparin. Patients need their APTT checked all the time. They need their D-dimer checked once a day, right? So it's critically important that blood tests are being done even more frequently compared to another ICU patient. For other ICU patients, it's usually once a day. Sometimes it can be twice a day, but it's most of the time once a day, right? So I hope that helps you understand a little bit more about ECMO and life support in general. I only welcome you to ask questions here, type them into the chat pad, or talk to me directly here. Click on the StreamYard link and talk to me directly here. If you don't have any other questions, I will move on with some other questions that have come in during this week. And the next question that I'm going to is coming in from Elisa. Hi Patrick, my name is Elisa, and my sister Shelby is also copied into this email correspondence. I am writing to you as my dad, who's 67 years of age, was just admitted into ICU this past Sunday evening, January the 5th, 2025. I stumbled upon a post of yours about another individual who was told their dad will never come off the ventilator. My dad is currently on ventilation, and they're talking about moving him to a tracheostomy by Monday, stating that is the day my sister's mum and I must make a decision. Oh, that makes me laugh. Not that the situation doesn't make me laugh at all, but I tell you what makes me laugh here. I can't believe how many families are getting told, oh, you must make a decision by such and such. And my response to that is, you don't have to do anything. If they ask you to jump off a bridge, would you jump off a bridge just because they ask you to? Just because they ask you to make a decision doesn't mean you need to make a decision. The timelines they're giving you might be more convenient for their agenda. But we'll break that down a bit further. So then, it feels forced, and we are all under pressure as this hospitalization was completely unexpected. Yes, that's exactly the point. It does feel forced. You can change the feeling. You are in control of changing the feeling. Right? Take control of what you can control. You are in control of changing the feeling. I understand you are Australian-based, but I was hoping there would be assistance you could provide for us in Florida, United States. Yes, I'm talking to people in the US every day, 7 days a week. I'm talking to people in the US, and most of our clients, actually, as a matter of fact, are in the US because of the sheer volume. We've got, 400 million people in the US. We've got around 25 million people here in Australia. So our content is wide-reaching. It's reaching people all over the world. And we have interviews and podcasts and testimonies from people all over the world, including most of them from the US. As I mentioned, they want to take my dad off the ventilator and put him on a tracheostomy. I'm not sure, is this the correct decision or not? I believe they want to do this to transfer him to an LTAC, which we are also wary or after reading some reviews. Without going into too much detail, my dad was admitted and found to be septic from a pacemaker that he had put in place on December the 16th, 2024. I would love to know what services you offer and how you might be able to assist us with this matter. I look forward to hearing from you soon. So, what services do we offer? Consulting and advocacy. Now, few things here, Elisa. Few things here, Elisa. First off, you don't have to do anything. Why are you responding to that perceived pressure? It's only perceived. You decide to react to it. You don't have to. You don't have to react to it. So that's number one. Number two, if you've watched this video from the beginning, what have I said right from the start? What are they doing to avoid the tracheostomy? Have you asked that question? Because that should be their primary goal. That should be their primary goal. Now, what you haven't Sunday evening, 5th of January. So what are the timelines for a tracheostomy? If the ICU has done everything beyond the shadow of a doubt, to avoid the tracheostomy and wean your dad off the ventilator, then it's kind of a 10 to 14 day window for a tracheostomy to be done. So what that means, if by day 10, 14, the ICU has done everything beyond the shadow of a doubt to get your dad off the ventilator and they're not succeeding, right? Because he's too sick, too weak, whatever the case may be, then a discussion around a tracheostomy is an appropriate discussion to have. But at the moment, we're just talking about a discussion. We're not talking about actionable steps, because you don't know what you don't know, right? So here is when a tracheostomy is a good thing. A tracheostomy is a good thing if they take action steps to move your dad off the ventilator, right? And it's promising that with a tracheostomy, they have a clear plan to succeed to wean your dad off the ventilator. That's when a tracheostomy is a good thing. And they take off all sedation. If you've listened to my case study earlier where I said, one of our clients was on truckloads of sedatives and opiates after a tracheostomy, that would be the wrong approach. So let's recap. If they've done everything beyond the shadow of a doubt to get your dad off the ventilator and the breathing tube and they haven't succeeded, right, then a tracheostomy after day 10, day 14 of intubation, breathing tube might be an appropriate discussion to have. If the goal is to do a tracheostomy, stop sedation, stop opiates, and wean your dad off that ventilator, that would be a good course of action. And then also avoid tracheostomy, and then also avoid LTAC, right? I have made countless videos about why to avoid LTAC, made countless videos about that, right? And then tracheostomy weaning off the ventilator in ICU, fantastic, good thing. If the goal is to do a tracheostomy and get your dad to an LTAC as quickly as possible, wrong move. Because an LTAC will be catastrophic for your dad, especially in Florida. An LTAC will be absolutely catastrophic for your dad. Just look up the online reviews and you know what I'm talking about. Next, you also need to be very mindful here whether they are only suggesting a tracheostomy or whether they're suggesting a tracheostomy and a PEG tube. Now, a tracheostomy with a view of stopping sedation, stopping opiates, and weaning your dad off the ventilator whilst in ICU without a PEG tube, right move. If they have done everything beyond the shadow of a doubt to try and avoid the tracheostomy. Tracheostomy with a PEG tube, wrong move. A tracheostomy and a PEG tube is almost like the entry ticket into LTAC, right? Many LTACs will not take a patient without a PEG tube. They only take patients with a tracheostomy and with a PEG tube, right? Now, from my extensive experience and also backed up by independent research, a nasogastric tube is perfectly fine. You don't need a PEG tube to get nutrition. Some ICUs that I worked in, we never did PEG tubes. Always managed nasogastric tube for up to 12 months even. No big deal, right? PEG tube requires surgery. It's a surgical procedure. You want to minimize surgery for your loved one. Also, PEG tube gives the perception of permanency for health professionals. The perception of a nasogastric tube is to have it there temporarily. That means the goal clearly is to wean someone off a ventilator, wean them off the nasogastric tube feeds, and then have them eat and drink again once the ventilator has been weaned, once the tracheostomy has been weaned. That is clearly the goal. PEG tubes have the perception for health professionals that this person will never eat and drink again. And no one gives an effort or makes an effort to get this person to eat and drink again. Nursing homes are full of patients with PEG tubes. It's terrible. It's like feeding patients in a factory line with PEG tube feeds. That can't be the goal of the care for people, or can it? Right? So, Alyssa, you need to be clear about what you want for your dad. They need to be clear about how to avoid LTAC, right? They need to be clear about how to avoid LTAC and how to wean your dad off a ventilator. Ask them for their plan. Clearly ask them for their plan, what to do to avoid LTAC and wean your dad off the ventilator whilst he's in ICU. When can he get mobilized, right? Also, bring it back to common sense once again. Bring it back to common sense. Do you think that it's common sense for your dad to have tracheostomy and a PEG tube? Do you think it's common sense for your dad to go to LTAC? Once again, tracheostomies have their time and their place. Right? Tracheostomies have their time and their place. Nothing wrong with the tracheostomy if all options have been evaluated and performed to wean someone off a ventilator and the breathing tube. Then a tracheostomy, I'm all for it. Right? But I argue that after 6 or 7 days in ICU, it's too early. Have they stopped sedation and gotten him out of bed? Have they mobilized him? Have they done physical therapy? Because if they haven't, it would be the wrong move to do a tracheostomy. Or it might be the wrong move to do a tracheostomy. So, Lisa, I hope that helps. I hope that helps. Here is another question that came in during this week that I want to elaborate on and that I think is really important. Another question that I want to elaborate on this week is, when is it appropriate to go from ICU to a step-down ICU? Now let's break down some terminology there. Many ICUs worldwide have sort of the high acuity ICU, or in English-speaking countries in particular. And then they have what's called step-down ICU in the US. That's when sort of people are still needing ICU, but they've already improved. They're sort of slowly but surely progressing towards being discharged from ICU. That's when you move patients to a step-down ICU. In the UK and in Australia, those areas are often called high dependency unit, or HDU. So there's a little bit of terminology. But when is it okay to go to step-down ICU or to HDU? When is it okay? I tell you when it's okay. When a patient, generally speaking, is hemodynamically stable, right? So they're no longer on inotropes, no longer on vasopressors. They're pretty much off all sedation and opiates. They have stable ventilator settings, right? So they might be in an SIMV or an ACV mode. So the ventilator might still be doing most of the work, but they might also be on 30% oxygen, and PEEP is 5 or 10 at the most, and they're reasonably stable from a ventilation point of view as well. With a tracheostomy, they wouldn't go to a step-down ICU with a breathing tube, I argue. I've never seen that, right? So they must have a tracheostomy in order to progress to step-down ICU or HDU, right? And they might even have already passed some spontaneous breathing trials, right? They might have passed some spontaneous breathing trials already. Okay, that is when it's okay to go to a step-down ICU, right? So I hope that answers that question, because again, you want to know what decisions are right for your loved one, what decisions are not right for your loved one, you know. So I'll be going for another 5 minutes. I still have time for a question. If there's a question that you want to ask, there's still people on the call. Please type your question into the chat pad. Or alternatively, I'll go back to the questions that have come in during the week. Gotta give me a second. I just gotta go to my emails. But step-down ICU or no step-down ICU, it's really critically important for you to understand. Tracheostomy or no tracheostomy, critically important for you to understand. You know, otherwise you could be in an uphill battle with your loved one and they may not get best care and treatment. Right? Another common frustration that we get, and we get that through our emails, is I want the doctors to start listening to me. Right? How do you get the doctors to listen to you? Well, first off, you need to ask the right questions. Right? That is the most important part. You need to ask the right questions, because once the doctors know you speak the quote-unquote secret intensive care language, that's when they will actually start to listen. Right? When they know you are a subject matter expert in your own rights because you get help from us, right? That's when things change. Nargisa says, my daughter has hypoxic ischemic brain injury. Is there a cure for that? I wouldn't know, Nargisa, without looking at all the medical records. How long ago was the hypoxic brain injury, right? What has led to it, right? Is she still in ICU? Is she at home? Has she had rehab, right? There are so many questions that need to be asked. It's not a one-size-fits-all, right? So I can't answer you that question without looking at the medical records, without talking to a doctor or nurse. You know, it is difficult for me to answer that question without having all the insights, right? And this is why I'm saying most families in intensive care, they completely underestimate how much it takes to answer a question, right? It takes decades of experience for me to host a live stream where I can answer pretty much any question, right? So can brain cells regenerate if they die? I believe they can, at least some of them, right? But most patients with a brain injury that recover, it happens over time with rehabilitation, with physical therapy, right? It happens over time. Right? That's the only way that can happen. You know, it only happens over time. But Nargisa, I encourage you to reach out to me at intensivecarehotline.com, so maybe we can do a quick 15-minute free consultation and then see where it leads us to. So go to intensivecarehotline.com and book a time with me there, or give me a call on one of the numbers on the top of our website. I am going to wrap this up in a minute, quite literally in a minute. So if you want help, go into intensivecarehotline.com, call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. We also have a membership for families of critically ill patients in intensive care. But also, if you like my videos, give it a like, subscribe to my YouTube channel for regular updates, click the notification bell, share this video with your friends and families, anyone you know has a loved one in intensive care, and comment below so I know what content you want next. If you need help with intensive care at home, go to intensivecareathome.com, call us on one of the numbers on the top of our website, or simply send us an email to info@intensivecareathome.com. With Intensive Care at Home, we're currently operating all around Australia, in all major capital cities, in all regional and rural areas. We are sending our critical care nurses into the home 24/7 to replicate an ICU bed at home. And we're also providing level 2, level 3 NDA support coordination in Australia. And we're also providing TAC and WorkSafe case management, in Victoria with Lucy McCotta. Thank you so much for watching this, even if you're watching this on replay. I'll talk to you again next week. Have a wonderful week. I wish you and your families all the best. Take care for now.